Welcome to the WoundRounds webinar on Medicare Part B billing, wound care supplies. This is a practical guide, and thank you for joining us today for this webinar. Before we get started and introduce our speaker, I'd like to go over a few bookkeeping items for participants. You're all muted, but you can ask questions using the dashboard on your right-hand side. You should have received a copy of our handouts in advance if you've been pre-registered for this webinar, but if not, rest assured we'll also send copies of handouts at the end of the webinar today. We're recording today's webinar, and you'll also get a copy of this URL so that you can watch an archive view of this webinar in your leisure after the conclusion of the webinar today, and you can also share that webinar with others in your facility. And lastly, I wanted to let you know that you'll get the contact information for our speaker, Amanda Smithey, so that you can reach out to her offline and ask any questions if you'd like. And you'll also get the contact information for WoundRounds, the sponsor of today's webinar, and you can reach out to them offline as well for demonstrations and for other interests. So a big thanks today for WoundRounds for making this all possible. And what I'd like to do now is introduce you to our speaker, Amanda Smithey. So Amanda is presenting today. She is a subject matter expert with deep expertise in the area of Medicare Part B billing for wound care products. And she joins the WoundRounds team, and she's a member of the Long-Term Care Solutions team. And we're pleased to have her on our team and also to have her presenting today. Before her experience at WoundRounds, she held some executive roles in advanced tissue, and we look forward to learning more about her background in wound care billing today as we get going on our webinar. Next, a word about myself. My name is Deborah Kurtz, and I'm the moderator of this webinar today, and I come to you with a background in healthcare, specifically in long-term care and wound care products. And so my consultancy works with healthcare organizations to help them build their top line. So at this juncture, I'd like to ask Amanda to officially kick off the webinar with a review of what our learning objectives are today, and to thank you so much, Amanda, for joining us on the call and imparting your knowledge. We do really appreciate it. Thanks, Amanda.
Thank you, Deb, for the introduction, and I want to thank everyone also for taking the time out of your afternoon to attend our webinar. Pretty much every week, every day, I have all sorts of conversations with people regarding Medicare Part B billing for wound care. Whether it's an individual facility, a DME company, or a distributor, it's always the same response regarding wound care billing. It's really difficult to get complete and accurate documentation, or it's really difficult to get the products to match with the criteria. I'm here to tell you that once you have a little bit of knowledge, it really is not that hard at all. This afternoon, I'm going to help navigate you through the ins and outs of Medicare Part B billing for surgical dressings. My goal for this webinar is to have each of you at the conclusion take a closer look at your current Part B billing program for wound care supplies and determine the steps that you need to take to optimize that cost savings and/or revenue stream. I promise that there will only be a couple of homework assignments, but trust me, these are going to be of benefit to you and to your facility's pocket. Take a look at the objectives. Our first objective is we're going to overview Medicare guidelines for reimbursement of surgical dressings. Second, we'll review product selection based on Medicare criteria for specific product categories. And finally, we're going to discuss evaluating your current Part B billing program for wound care supplies. To give us an idea of an actual estimated reimbursement amount, let's take a look at our first resident case study. This wound happens to be the treatment nurse's problem wound. The wound is documented as a stage 3 pressure area on the left buttocks, measuring 7.5 by 4.3 by 0.25 with moderate drainage. Due to that amount of exudate and a small amount of slough still present in the wound, the treatment nurse is using a calcium alginate with a bordered gauze for a daily dressing change. Based on Medicare Region C fee schedule, the estimated reimbursement revenue for these products is $620.10. As we continue our discussion today, through the explanations of eligibility and fee schedules, it'll make more sense how we got to that estimated amount, but I wanted to give everybody an idea of the potential dollar amount for one treatment while we get started. start thinking a little bit about what your own facility's process is for Part B billing for wound care supplies. With the uncertainty today of reimbursement and cuts in Medicare, it's really imperative for facilities to optimize all their reimbursement potential, whether that means bringing the billing in-house to create another revenue stream or utilizing those third-party billers to alleviate the overall costs of products. So start thinking about this, and let's do a quick poll to see what the bulk of everyone out there is doing today currently with their billing.
Thanks, Amanda. This is Deb again, and I'm hoping that everyone can see in front of them that we've switched screens and we've got a poll up right now because we'd like to learn how everyone on the call today is currently handling their Medicare Part B billing for wound care supplies. So if you could take a moment to vote here among your options. And we'll share the results of this poll momentarily after everyone gets a chance to vote. I see the votes coming in, so thank you all for voting. And as soon as I see the numbers subside, we're going to share this information with the rest of you, and you can see how most facilities are handling this function today. So as you can all see, we have a few favorites here. So internal billing seems to be our #1 in terms of what most facilities are doing today, followed by nothing. And I think those are both amazing extremes, and I know that this is something to which Amanda is planning to speak in a moment. So Amanda, would you like...
Sorry. Thank you, everybody, for taking time to vote for us today. What I want to do now is kind of go over those 4 different options so that everybody has an understanding of what each one means and what their responsibilities are for each one of those options. The first option is internal billing, and that's when the billing is done in-house by the facility staff or up at a corporate location. It does require for facilities to have their own supplier number and also to be registered through the National Supplier Clearinghouse. By bringing that billing in-house, though, it does create a revenue stream for the facility. All the products, though, are still purchased through the distributor for all residents. One of the biggest keys to making internal billing work is to have that complete and concise documentation and also to have a staff member that's able to do that billing for you. The second option is a full assignment provider. These are your national rehabs, your advanced tissues, your Medimarts of the world, basically your DME companies. With this option, the documentation is provided from the facility to the DME. The DME is going to all claims on behalf of the under their own supplier number and then ships those billable products to the facility at no cost to the facility. That reimbursement revenue remains with that DME. This can get a little bit tricky with the sharing of documentation. Again, that key is to have complete and concise documentation. The DME company might provide an on-site rep to gather documentation, or they might require the nursing staff to complete order forms or fax over documentation. Your third option is the fee-for-service provider. Your fee-for-service provider is a little bit of both option 1 and option 2. It's not as common as it had been several years ago. In this particular option, the facility is still required to have a supplier number, and the fee-for-service provider is going to bill on behalf of that facility. The biller does charge a set fee or a percentage per claim submission, and the facility is also still responsible for purchasing all products. Option 4 is the doing nothing option, and at this point that means that that facility is eating the cost of the products and they're probably leaving money on the table. It doesn't matter which of the first 3 options that your facility determines is the best fit for your facility, as long as you're doing something to capture that cost savings and or that revenue stream. In addition, the guidelines that are set forth by Medicare are the same no matter what option it is. What is relevant is understanding those guidelines and documenting each and every wound in the facility. Once you have that little bit of knowledge and a handle on the documentation, the reimbursement is really very easy. To start off, let's figure out which residents are even eligible. How do we know which residents are Part B eligible? The most obvious answer is to harass the business office staff. Of course, they know, they deal with it day in and day out. But a real simple way to get around about idea is to think of how long a resident has been at the facility. One of the most common misconceptions is that Medicare pays for the bulk of nursing facility care, when in all actuality, Medicare is only paying for about 10% of the nation's nursing facility care. Medicare Part A covers those first 100 days of a SNF stay. This is reimbursed as a per diem rate based on RUG rates. Of course, there are other conditions that need to be met and benefit periods to consider with Medicare Part A, but in general, just think those first 100 days. After those 100 days, if a resident has Medicare Part B coverage, that's when that benefit will kick in. Under Medicare Part B, certain supplies, such as your surgical dressings, are reimbursable. Medicare Part B is going to reimburse surgical dressings at 80% reimbursement of the Medicare-approved fee schedule. In the nursing home world, that remaining 20% is typically covered by Medicaid, a Medicare supplemental policy, or Medicare choice plan. There is from time to time a situation where there is that private pay resident, and that 20% remaining balance does become the responsibility of the resident or the resident's family. Now that you have an idea that a resident is eligible and you do all the work to submit that claim, it's important to know where it's going to go after that. And it's going to go to one of the 4 DME MAC regions. If you take a look at the map, it has the breakdown of all 4 of the DME MAC regions. DME MAC is Durable Medical Equipment, Medicare Administrative Contractors. It's really important to know what your region is. One of the best things is that these DME MACs are a great resource. They provide you with information on the LCD. The LCD is the local coverage determination, and what you would want to do is visit their website, look up the LCD for surgical dressings, and it's going to give you all the information that you need to know regarding the HCPCS codes for different products, and it also gives you the guidelines based from Medicare on what is allowable and what is not allowable. And we're going to cover all of those here today. So what is the specific criteria of a wound for reimbursement? First and foremost, it's Medicare's favorite reimbursement phrase, medically necessary. Documentation has to show that the use of surgical dressings is medically necessary. You'll hear me harp on it a lot today about documentation because that really is the key to making billing smooth. Wounds can either be related to a surgical procedure or needs to have been debrided. When we understand related to a surgical procedure, that makes sense. But what exactly is meant by debridement? Debridement can be any one of the 4 that I'm getting ready to review, or it can be a combination of those as well, too. Surgical debridement is what we typically think of when we think of debridement. It's the use of a scalpel or other instrument to cut out the necrotic tissue. Enzymatic or chemical debridement is that topical application of enzymes. An example I'm sure most of us are familiar with is Santyl. You always want to use caution there with enzymatic debridement and contact sensitivities. Autolytic debridement is the use of occlusive dressings. During autolytic debridement, the body is using its own enzymes to break down that necrotic tissue. Some examples of some occlusive dressings are your hydrogels, your alginates, hydrocolloids, foams, and thin films. Mechanical debridement is the least popular of the debridement options and is really being phased out due to the fact that it is a non-selective form of debridement. Non-selective basically means that during that mechanical debridement, not only is that necrotic tissue removed, but so is the viable tissue as well. So which wounds are covered? You've got your pressure ulcers, your stage 2 through stage 4, and unstageable, diabetic ulcers, your venous insufficiencies and arterial ulcers, your surgical wounds. My big rule of thumb here that I like to tell nurses is that as long as it is an open wound, it's been debrided, has measurements, and has been documented as being medically necessary for that specific treatment, the products are reimbursable. There are some definite wounds that are not eligible. You have your stage 1 pressure ulcers, which by definition is not an open wound, your first-degree burns, venipuncture, arterial puncture sites, and wounds caused by trauma which do not require surgical closure or debridement. Your examples of skin tears and abrasions. A quick note about that, though. Your skin tears and abrasions, they can be reimbursable when debridement is involved. For an example, if a resident has a skin tear on their left arm and an occlusive dressing, such as a thin film, is being utilized, that is considered a form of autolytic debridement, meaning that that skin tear is being debrided, and then that thin film is reimbursable. The hardest part and what causes most people to give up on the Part B billing for wound care supplies is that documentation piece. It's crucial, again, to have accurate, consistent, complete documentation on all wounds, which, again, should be a no-brainer for a facility because that's what's also going to help a facility avoid litigation. So why not make it a focus to make sure your documentation is where it needs to be? If you have handy near you right now, take a look and pull out your current requirements for wound assessments. Kind of follow along as I list out the guidelines and check off that each of those is also included in your current assessments. Over the next couple of days, and this is going to be homework assignment number 1, review and make sure that all of your assessments are being completed each and every time by the nursing staff, and they include all of these guidelines in them. First, let's take a look at wound type. Certain products are only reimbursable for certain types of wounds, so that makes sense. You wouldn't need a compression wrap or compression stockings for wounds other than those venous insufficiencies. So make sure that the nursing staff is being specific. If it's a pressure ulcer, list pressure ulcer. Diabetic ulcer, list diabetic ulcers. Make sure that your nurses understand the different definitions and the different types of wounds. Location. Where is that wound located? Use your Mr. Man or your Mr. Body or body maps to help illustrate where the location is at. Measurement. Measurements should always consist of length times width times depth. Length is measured from head to toe at the greatest length, and width is across the body at the widest point. For depth, utilize that cotton tip applicator method. If the wound base is not visible and depth cannot be determined, document that. Classification. Only pressure ulcers by definition are staged. Follow staging guidelines that are set out by the NPUAP, and remember to not reverse stage. It is okay to document a healing stage 3. The Wagner grade could be used for diabetic ulcers or just a classification for full thickness or partial thickness. Full thickness or partial thickness will work for all other wound types. Drainage amount. It's always great to have documented the type of drainage, but really both is the ideal. Include the drainage amount, none, minimal, moderate, heavy. Remember that when doing a dressing change, though, and there's evidence of exudate within that dressing, to take that into consideration when determining the exudate amount. Infection. Again, this is another one of those areas where there are certain products that it makes more sense to use when there are signs and symptoms of infection. That's why it's important to make sure that that's documented in your notes. Document any odors, drainage color, if the resident's on any antibiotics, any labs or cultures taken, anything that would indicate that there's signs and symptoms of infection. Your treatment products and your frequency, be as specific as possible. Every little piece of gauze counts, literally. For our second resident case study, we had a resident with a wound that was healing, and the nurse had a handle on the treatment. All the documentation supported the guidelines and established a medical need for the product. Because of the location on the resident's sacral area, the nurse was using a hydrocolloid shape for better coverage and fit. The sacral wound was documented as a stage 2 with minimal drainage and a measurement of 4.2 by 2.5 by 0.1. The estimated reimbursement revenue for this particular treatment is $355.32. A couple times by now you've heard me mention the terms HCPCS and Fee Schedules. So let's discuss exactly what those two terms mean. HCPCS stands for Healthcare Common Procedure Coding System. Every product is assigned a HCPCS code by Medicare. The HCPCS codes group like products based on product category definition and also by product size. For the most part, the HCPCS codes assigned to a product make sense. On this slide, I have two codes for collagen products. You can see the A6021 is a collagen dressing, sterile, pad size 16 square inches or less each. The next code, the A6022, is also for collagen, but it's a larger size. Manufacturers are also an excellent resource when inquiring about a product's HCPCS code, as well as your local DME MAC. Each HCPCS code that's reimbursable is also going to be assigned to a fee schedule. It does not matter the manufacturer of the product or the size as long as it is within the range of that HCPCS code. So basically what I'm saying, that all products with that HCPCS code are going to be reimbursed based on the same fee schedule. Take a look at A6196. All Alginates 2x2, 4x4, containing silver, all of those are going to be grouped under this HCPCS code, and all will be reimbursed on the same fee schedule of $7.90. As you can imagine, this does leave for a wide range in actual profit from reimbursement. Some DME companies will only provide generic versions of products, and the reason behind this is to have that higher profit margin. You might have also noticed some odd sizing on dressing packages, maybe a 4.25 by 4.25 alginate dressing. Manufacturers starting producing products a little bit on the larger side to bump up the reimbursement of a specific product. Fee schedules, again, can be found on the DME MAC's websites and are broken down for each region by state. The fee schedule can vary a little bit from state to state, but not usually more than a couple pennies when it comes to the surgical dressing category. Quick note on covered dressings. You've got both your primary and secondary dressings that are covered. Again, it's crucial to include all products being used on a dressing change when seeking reimbursement. Gauze, tape, ABD pads, Curlex, cling, all of that is reimbursable, and it does begin to add up. For dressing size, my rule of thumb is always to add an inch to the length and an inch to the width, and that's considered an appropriate dressing size. And just in case, I know I'm not the best at measurement conversions, but do keep in mind measurements are done in centimeters for wounds, and then the dressing sizes of the dressings themselves are in inches. So 1 inch is roughly 2.5 centimeters, and that helps keep the math a little easier. Our non-covered dressings and treatments. There's been a lot of conversation this year in the billing world about G-tube sites. G-tube sites are not covered unless the area is documented as being infected. So that's one thing to keep in mind. Wound vacs, unfortunately, are also not billable for nursing facility residents. They are billable in home health. The dressings that are used in conjunction with the negative pressure treatment are not covered unless it's a product not typically found in the kits. An example of that would be if a doctor ordered a collagen or calcium alginate and they wanted that to be used in conjunction with the vac, that particular product would be reimbursable. Enzymatic debriders, again, we talked about that when we were talking about enzymatic and chemical debridement. Those are also not covered under Part B. So the Santal is not covered, but any dressings that you're using in conjunction with Santal, whether you're also needing to hydrate the wound or manage exudate or even just cover that Santal, those dressings are covered. And Medicare does not reimburse for dressings that are used for protection and prevention. Resident case study number 3. A Part B eligible resident has a healing stage 3 pressure area to the left trochanter with a measurement of 2.5 by 1.5 by 0.2. Drainage is documented as none. Current treatment indicates use of hydrogel gauze and border gauze with a daily treatment change. The nurse's goal for this particular wound treatment was to keep a moist healing environment, and she was utilizing that hydrogel gauze for that. The estimated reimbursement for these products is $183.30. One of the things I wanted to point out with the 3 case studies thus far is the difference in reimbursement amount per resident. We had one reimbursement amount at around $620, another around $350, and this one at $180. So the products that are selected make a huge difference in terms of reimbursement amount, and it really depends on the severity of that wound and what the nurse is trying to accomplish with the treatment. Now we'll talk a little bit about the specific product categories and what the criteria is for reimbursement. Before we discuss those product categories, I do want to point out a couple of things. The information that I will be presenting is based directly from the LCDs for surgical dressings. And these are guidelines and recommendations for what Medicare considers is best practice for use of those products. These guidelines do tend to fall in line with manufacturer recommendations. It does not, however, mean that a treatment is bad or wrong if it does not follow those guidelines. It also does not mean that a bad treatment would not be reimbursed. We all can think of those circumstances when a doctor's ordered a product off formulary, but that was what was actually working for the resident and that was what was best for that particular resident. If the documentation supports the need of that product and you submit that documentation with the claim, sometimes it will be approved. When working with third-party billers, ask what their policy is regarding these outside the norm treatments from time to time. Again, it may be something that they're willing to submit the claim for, provided that they do have that additional documentation. Calcium alginates, the A6196 to A6199. Primary function of the calcium alginate is to manage that exudate and maintain a moist wound environment. Alginates are also great at facilitating autolytic debridement and can absorb sometimes up to 20 times their weight. Many will also form a gel within the wound. The guidelines for reimbursement are full thickness wound, which by definition includes your stage 3, stage 4, and unstageable pressure ulcers, with moderate to heavy drainage documented. The allowables are for up to 30 pieces per wound per month. And remember that frequency and amount of product supplied is dictated by the frequency of change recorded in the documentation and on the TAR. Collagens are the most abundant protein in the body, and a collagen dressing is going to increase that fibroblast production, stimulating new tissue development. These products are also going to support debridement and, again, are ideal when there's a stalled, clean wound. They come in sheets, particles, gels. Collagens are expensive, and it's also one of the highest reimbursable product categories within the surgical dressing category. The allowables for collagen is 30 per wound per month for sheets. And for gels and particles, make sure you're referring to the manufacturer's guidelines for application. The primary purpose of a foam dressing is to absorb that exudate and provide thermal insulation. Because it is supposed to absorb exudate, it makes sense for a guideline to be that a wound needs to be documented with moderate to heavy drainage. Foams are only allowable for 12 pieces per wound per month, and this does fall in line with manufacturer recommendations on the utilization. At the beginning of a treatment, you may run into a situation where that wound might require more frequent changes due to that exudate amount. In those instances, there are other products that are more suitable and more cost-effective for daily dressing change to manage exudate, such as possibly a calcium alginate in combination with ABD pads. As that treatment then continues and the wound responds, then move to that foam product with a three times a week dressing change. Hydrocolloids are going to seal off and protect the wound. These dressings are impermeable to bacteria and other contaminants. If a wound has a heavy exudate and a hydrocolloid is used, that exudate has the potential to pool or pocket underneath that dressing and will cause additional maceration. For that reason, it is recommended that wounds be documented with only light to moderate drainage for the use of a hydrocolloid. Similar to foams, the allowables are 12 pieces per wound per month. And next we have the hydrogel category. Obviously, the hydrogels are going to rehydrate the wound and add in that moisture to help facilitate that moist wound environment. Hydrogels come in amorphous gel, sheets, and impregnated gauze. The allowable for the hydrogel gauze and sheets is 30 pieces per wound per month. For the gel, the maximum amount is about 3 ounces per wound per month. Because it does add in that moisture, hydrogels are not considered medically necessary in combination with a calcium alginate, considering the alginate's purpose is to manage exudate. Hydrogels will dehydrate quickly without an appropriate secondary dressing. Thin films or transparent dressings are designed to cover and to protect. These dressings are adhesive and semi-permeable, meaning that they are waterproof and impermeable to bacteria, but they are breathable, allowing for oxygen exchange. Medicare's recommendations are for wounds documented as partial thickness with minimal drainage and 12 pieces per wound per month. Some of the other commonly used products that you'll see that are going to be reimbursable are your gauze. Gauze is reimbursable at 3 times per day or 1 time a day with a bordered. So your bordered gauze would be just a once a day, 30 pieces per wound per month. Your impregnated gauze, such as your Vaseline gauze, again, that's going to be reimbursable at a treatment change of 1 time a day or 30 pieces per wound per month. Your specialty absorptive, those are your ABD pads. Those wounds need to have documented moderate to heavy exudate and are at 1 time per day or 1 time every other day for those that have a border. Tape. Tape is not ever needed when product has an adhesive border, and the quantity of the tape must reasonably reflect the wound size. Good guideline to go by, tape that's 1 inch to 3 inches, 2 rolls per month. Tape that's 4 inches, about 1 roll per wound per month. And our final resident case study. A Part B eligible resident has an ongoing venous insufficiency to the left lower extremity. The wound is measured at 4.5 by 2 by 0.25. The wound is documented as full thickness with moderate drainage. The treatment ordered consists of a collagen as the primary. A specialty absorptive and the compression wrap are also used as secondary with tape indicated for adhesion. The treatment changes every other day. And the estimated reimbursement total for this particular resident is $422.55. All 4 of the resident case studies all came from the exact same facility and were residents eligible for Part B reimbursement within a 1-month time frame. A little bit of background regarding this facility. The licensed bed count is 99. The current census on the date that these claims were submitted was 94. The facility was doing their own billing internally. They did have a manufacturer-specific formulary. Their cost of treatments for these 4 residents was $632.51, and their reimbursement revenue for those 4 was estimated at $1581.27. I worked with this facility in assisting to determine their cost of products per treatment and comparing that with the reimbursement revenue based on the fee schedule for Medicare for Region C. The protocols were reviewed and adjusted to fall more in line with Medicare's recommendations, and these were all things that the facility did ahead of time in order to optimize their reimbursement revenue and to kind of get more of a hold on their wound care program overall. So how can you have that same success at your facility? And let's talk a little bit about how to evaluate your current Part B program for surgical dressings. The first thing that you're going to want to do is you want to determine your current process. Are you using internal billing? Do you have a full assignment provider? Are you doing fee for service? Or are you currently not doing anything at all at the present moment? Billing starts to fall apart when the documentation is not complete, consistent, and accurate. And there's lots of solutions that are available to assist facilities in making sure that their wound care documentation is where it needs to be. So the first thing that you need to do is check your documentation and review that. Are there holes in your documentation? Is your documentation complete? Are there inconsistencies in the documentation, such as errors in staging, maybe some nurses that are reverse staging? Take a look at that. If education is needed, then find a way to get that education there for those nurses. Are your protocols written to optimize reimbursement based on Medicare guidelines? Take a look at your protocols. If you have a protocol that's written for the use of a foam product on a minimally draining wound, you might want to adjust that. Maybe use a hydrocolloid in that situation as opposed to the foam product. Also make sure that those products that have a longer wear time are not being utilized for daily dressing changes, such as your foams and your hydrocolloids. Have discussions with your biller regarding eligibility and products. If you're doing the billing in-house, make sure that the person that's doing the billing is capturing all the wounds that are eligible, not just those stage 3 and stage 4 pressure ulcers that tend to be the most costly to treat. You don't forget about those venous insufficiencies as well. Those rack up a lot of costs too. Are all the products being utilized in the treatment being billed, both the primary and the secondary? If products are being supplied by a biller, do the products follow the facility's formulary? Are the correct quantities of products being supplied? And all of your third-party billers will be able to provide you with different types of reports that will show you your product usage and the quantities that have been shipped in per resident. So that can give you an idea in terms of making sure that you guys are capturing everything that you should capture. And then a cost versus reimbursement comparison. Audit your own facility. Review the documentation. Consult with the business office to determine those eligible residents. Then take the time to compare the cost per treatment with the current fee schedule. If you're doing nothing, you will then have an idea of what you could potentially be saving. If you are billing, this will also help you to evaluate if you're capturing all those eligibles and products coming in are indeed the products documented for the treatment. By knowing your own cost of products and knowing the fee schedule for those products, it also gives you an advantage in negotiating prices with your distributor to get that deeper discounted price. In all, the evaluating is not that difficult of a step when the end result is an increase in cost savings and or reimbursement revenue. Here are some of the web addresses for the DME MACs. I've also included the website for CMS. All the information that we presented today is from all of these websites, so you can feel free to take a look at that. On the CMS page, if you head down to the Durable Medical Equipment Center, there are links to the different DME MACs, as well as copies of the supplier manuals and the applications for supplier numbers in the National Supplier Clearinghouse. And I want to thank you guys again for taking the time to navigate through Part B billing for wound care dressings. I hope I was able to give everybody a little bit of a greater understanding of the requirements and why some things are the way they are in terms of the products and billing. I'll keep everyone posted as I'm traveling around the country, and hopefully next time I'm in your area we can meet up for a discussion. Remember your homework assignments, review your wound assessment requirements, are there holes in your documentation, and evaluate your current Part B billing program. Are you set up to optimize your cost savings or reimbursement revenue? And please don't hesitate to contact me with any questions or for any assistance. Thank you again.
Amanda, thank you for that great insight in how to maximize your Medicaid eligible reimbursement. That was a fascinating discussion, and we're very thankful to have your expertise on the phone today. So as we had promised, we want to open the floor up to questions from Amanda. We have ample time remaining in this webinar today, and like to give a chance for participants who have a good general question that's applicable to many. We'd certainly like to ask that question now. So as I'm taking a look at and seeing what questions have come in, and again, let me reemphasize one more time that we'll be handing out the copies of this deck again following the conclusion of this webinar today to people who may have registered late. I do see a question that's come in for Amanda, and I'd like to see if we can get Amanda back on the line to answer this one today. So the first question that's come in has been on the nature of the competitive bidding process and how it might be impacting Part B supplies for wound care. And I'm wondering if Amanda might want to speak to this trend in our industry.
I can do that. At the present time, wound care supplies or surgical dressings is not currently a part of round 2 for competitive bidding. The current categories are your oxygen supplies, I think your standard wheelchairs, both the power and manual, scooters, enterals, CPAPs, hospital beds, negative pressure, and I might have missed one or two other ones, but surgical dressings is definitely not involved in round 2 for competitive bidding. One thing that you might see is there might be some changes throughout your region in DME coverage. There are some DMEs that may not win bids. They might consolidate with other DMEs or pull out of that area altogether because they aren't able to provide service for some of the categories that are in the competitive bidding. But as of right now, competitive bidding does not affect wound care supplies.
Thank you, Amanda. Next question is, how can you tell if there's missing documentation or holes in your documentation? And I know that you stress this as an important part of making sure that you have maximum opportunity to collect on your reimbursement. So perhaps you might give us some tips on that, Amanda.
Really, it's just a matter of sitting down and going over your documentation. Take a look at there's 11-point assessment that's brought down by guidelines from the NPUAP and the WOCN. Make sure that all of those 11 points are in your documentation so that way that the nurses, when they're doing their assessments, they're documenting on all of those 11 points. The best way to do that is just to take a look at it and see that it's all there.
Thank you, Amanda. So time for a couple more. So here's a good question. So what if we ordered some products and they aren't reimbursable? Then what are we supposed to do?
Well, the guidelines I reviewed are just that. They're guidelines. If the documentation supports the use of the product as being medically necessary, then there's a chance that Medicare will accept that claim. It might mean that you have to submit additional documentation. If you're using a third-party biller, ask your third-party biller their policy on orders that would fall outside of the guidelines. Those extenuating circumstances, as we all know, come up from time to time, and they might be willing to accept that order. The key is making sure that it's documented and it shows that it's medically necessary. The other thing is also take a look at utilizing products that are reimbursable to manage that current goal, and then change that treatment to the desired one once it falls more in line with the guidelines.
Thank you, Amanda. So some more questions have come in, and here's one. The reimbursement amounts that you mentioned today, Amanda, were those monthly reimbursement amounts?
Yes, that was the monthly reimbursement amount. And all of those reimbursement amounts can be found, that facility was in Virginia, so we used the fee schedule for Virginia from Region C.
So Amanda, we had one last question about how to find the fee schedule per state. So if you all don't mind, I'm going to quick zoom back to that slide in the beginning of this deck so that we can show that one more time, because I think we had somebody join on the call late. And I believe it is this slide here, correct, Amanda?
Yes, actually, if you don't mind taking them back to the list of websites.
At the very end, and then here's the URL for those websites. Okay. So please go ahead.
Okay. That's going to be the easiest way to find the fee schedules. Go to whatever region it is that you're currently in, and there should be a tab there. It's a little different on each page, but there should be a tab there that has local coverage determinations, and then another tab that says fee schedule. When you click on the fee schedule, it's going to give you different options, and you want to select current fee schedule, and you want to look up the surgical dressing category, which they may have listed as SD. And then once you find that, the fee schedule is going to be posted for you by state, and it's also going to include the HCPCS codes for the product. It doesn't usually include the product categories. So what you may want to do is take the products that you're curious about finding the fee schedule for, write down those HCPCS codes, and then look at the fee schedule that way. If you still are having issues trying to locate that, feel free to shoot me an email offline or give me a call, and I can walk you through that.
Amanda, thank you. I think we still have time for a couple more, and I'm trying to keep towards general questions that would apply to everybody, but here's one about the time frame for wounds. So if a wound began over a year ago and is still not healed, and this wound care treatment nurse is interested in treating it today, she wants to know, is there a time limit on the duration of the wound for Medicare Part B billing?
No, there is not.
Great to know, especially for those with chronic non-healing wounds. Here's another one I think has some interest to the general audience. So if we have a Medicare patient, the question is are they always paid at 85%, even if there's a procedure that's performed in an acute care setting?
I think that probably is pertaining more to procedure codes than it is to dressing, like surgical dressings and the reimbursement for surgical dressing. So on that one, I'm not sure on that. Does that make sense?
Thanks. I can appreciate that, Amanda. I know that some of the questions that are coming in are very specific to very certain situations and certain patients and certain disease states. So I know that those might be best answered offline. But I'm checking to see if there's any other general questions that might benefit the entire audience to go through now and make sure that we've captured them all. And I believe that we have. So what I'd like to do is zoom ahead and talk about next steps from here. So as you see, you have Amanda's contact information here. But I also wanted to thank our sponsor today and also bring to light the fact that a lot of what we've spoken about today is the importance of documentation, making certain that it's complete and that it has no holes and that it's completely accurate and relevant to the types of wounds. And that's the driver behind maximizing reimbursement opportunities. And our sponsor today, WoundRounds, automates the wound care documentation process. And so if you would be interested in seeing a demonstration on how this documentation process is automated, we have the WoundRounds information here on this slide, and we also have the contact information of Corey Fosco at the end of this presentation today. So wanted to make certain that you knew our sponsor has a hand in helping to improve reimbursement rates for facilities. So thanks to WoundRounds for making this information available to us today. So I also wanted to give you a heads up on what's coming next. Continue to watch your email. If you were registered for this webinar today, it means that you're on our email list, and we're looking forward to sending some more information your way from today's call. So we'll be sending you out, along with our thank you for joining this call today, you'll receive a URL for the archived copy of this webinar, which enables you to review this information one more time or to share it with somebody else that you know or within your facility. So look for your email from that. You'll also, one more time, want to make sure you know, get a copy of the handouts that we went over today in this presentation. So another opportunity to get a copy of these valuable handouts. Lastly, I'm not sure how many of you are going to the American Healthcare Association and NCAL conference that starts October 7th through 10th, but we'd love to see you stop by at the WoundRounds booth if you're down in Tampa. So please come by and see us in booth 1240. And we also have some exciting new research that we're presenting there on a poster session that we presented at the recent SAWC Fall Conference, the Symposium of Advanced Wound Care Conference. We had a poster presentation there about how a facility reduced its facility-acquired pressure ulcers by 83%. So we'd like to show you that information. So lastly, I'd like to thank everybody for joining us here today, and make sure that everybody had a chance to answer the questions that they had. And if we didn't get to your question today, please feel free to follow up with us afterwards. So on behalf of Amanda Smithey at WoundRounds and myself, Deborah Kurtz, we want to thank you today for joining the webinar and hope that you got a lot of great valuable information out of this. Thanks again.